This lecture will describe endoscopes. To help you understand endoscopes, we will discuss 4 topics. The first is about the digestive and gastrointestinal tract among the organs of the body. The second is about common gastrointestinal diseases. The third is about endoscopy. The fourth is about endoscopic treatment. Let's talk about digestive organs first. The digestive organs consist of the digestive tract, which is responsible for digesting and absorbing food and drink, taken in through the mouth and excreting them through the anus, and the parenchymal organs, which are responsible for substances and metabolism that aid digestion. The digestive tract consists of the oral cavity, pharynx, esophagus, stomach, small intestine, large intestine, and anus. The upper gastrointestinal endoscopy covers the esophagus, stomach, and part of the duodenum, while the lower gastrointestinal endoscopy covers the anus to the colon and the end of the ileum. The lower gastrointestinal endoscopy covers the lower gastrointestinal tract from the anus to the large intestine and the end of the ileum. Explain the role of the esophagus. The esophagus is an elongated luminal tube approximately 25 cm long. It passes through the dorsal aspect of the trachea and is connected to the stomach's junction. It carries food and drink taken in through the mouth to the stomach by means of repeated contractions and retractions and peristalsis. The wall of the esophagus consists of 3 layers from the endoscopic surface: the mucosal layer, the submucosal layer, and the muscularis propria. The serous membrane, which is found in other organs, is non-existent. Explain the role of the stomach. The stomach secretes a variety of digestive enzymes. Among them, digestion is carried out by pepsin, which is secreted by the principal cells of the fundus gland, and by peristalsis of the stomach. The wall of the stomach consists of the mucosal layer, submucosa, muscularis propria, and serosa from the surface that can be observed by endoscopy. Explain the role of the large intestine. The large intestine consists of the cecum, colon, and rectum, in order from the top. The colon is divided into the ascending colon, transverse colon, descending colon, and sigmoid colon, starting from the cecum. The large intestine is an organ with a lumen about 1.5 meters long, and the transverse and sigmoid colon are elongated. The role of the large intestine is to absorb water from digested food and drink, and it rarely performs digestion. The following topics will discuss the basics of gastrointestinal diseases. Some of the most commonly known digestive disorders include these types of diseases. Reflux esophagitis is a disease of the esophagus. Gastric juice refluxes into the esophagus and digests the esophageal mucosa, causing erosions and ulcers. Symptoms of heartburn and acid reflux are observed. Endoscopic observation shows longitudinal erosions and ulcers in the lower esophagus. Esophageal cancer is classified into squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is the most common type, while adenocarcinoma is mainly known as Barrett's adenocarcinoma. Early-stage cancer is defined as cancer that remains in the mucosal layer, while superficial cancer is defined as cancer that remains in the submucosal layer. Esophageal cancer has no symptoms in its early stages, but as the disease progresses, patients may complain of dysphagia and chest pain. Early-stage cancer can be detected by iodine spraying and endoscopic image enhancement, which is said to lead to early treatment. Helicobacter pylori infection is one of the diseases of the stomach. It is considered that the root of infection may be through mouth-to-mouth contact with a parent who is a carrier of the bacteria during childhood or by drinking well water. Helicobacter pylori infection causes chronic gastritis, gastric and duodenal ulcers, gastric cancer, and gastric malt lymphoma. Persistent Helicobacter pylori infection causes chronic gastritis. Chronic gastritis leads to gastric gland reduction and intestinal epithelialization, followed by atrophic gastritis. Endoscopic diagnosis of atrophic gastritis is used to determine if the patient is currently or once was infected with Helicobacter pylori. Helicobacter pylori eradication therapy can contribute to the prevention of the progression of current atrophic gastritis or the development of gastric cancer. This does not mean that gastric cancer will no longer occur, so regular endoscopies are necessary. Gastric cancer is an epithelial malignancy arising from the mucosa of the stomach. The cause is considered to be Helicobacter pylori. Early-stage gastric cancer is defined as cancer that remains in the submucosa, with or without lymph node metastasis. In contrast, advanced gastric cancer is defined as invasion deeper than the intrinsic muscularis propria. Most early-stage gastric cancer is asymptomatic, and there may be no symptoms even in the case of advanced gastric cancer. When it becomes large enough to obstruct the pylorus, anorexia and vomiting may occur. Colon polyps are collectively referred to as localized bumps protruding into the large intestinal tract. Colonic polyps are classified as neoplastic and non-neoplastic. Neoplastic polyps are mainly adenoma, while non-adenomatous polyps are mostly hyperplastic polyps. Adenoma are partially cancerous and will be removed. Next, we will discuss endoscopy. The two types of endoscopy commonly heard of are upper gastrointestinal and lower gastrointestinal examinations. The upper gastrointestinal examination can be performed by either the oral or nasal method. This section describes the examination of the upper gastrointestinal tract using the oral method. A scope is inserted through the mouth to observe the esophagus, stomach, and part of the duodenum. The examination is not always easy due to the pharyngeal reflex, but it may be performed under sedation. The forceps openings are designed to be wide in order to deliver various. Next is the nasal method of upper gastrointestinal examination. In the nasal method, a scope is inserted through the nose and the esophagus, stomach, and duodenum are observed in the same way as in the oral method. The nasal method is said to be easier than the oral method because the patient can talk while undergoing the examination. However, the narrowness of the scope is limited due to the passage through the nose. The nasal method is not suitable for the use of instruments and devices that can be used with the oral method. For this reason, nasal scopes are often used mainly for examinations such as medical examinations. In addition, because the forceps opening is narrow, it takes time to suck out any remaining water in the stomach. Next is the lower gastrointestinal tract examination. A scope is inserted through the anus to observe the entire large intestine. While the upper gastrointestinal tract examination can basically be performed with fasting from the night before. The lower gastrointestinal tract examination requires the use of a laxative. Depending on the drug, approximately 2 liters of laxative is taken to flush the bowel. The examination is performed while the bowel is distended, so abdominal distension is easily felt. The transverse colon and sigmoid colon tend to stretch the intestine, and the patient often complains of pain when stretching the intestine. Compared to the scope used in the upper gastrointestinal tract, it is characterized by its larger diameter and its ability to vary its hardness in steps. Next is the endoscopic therapy. In endoscopic therapy, hemostasis for gastrointestinal bleeding and resection of early-stage cancer will be explained. These are examples of hemostatic methods for gastrointestinal bleeding. First, there is the local injection of harmonic sodium epinephrine solution. Localized injection around the bleeding site reduces the influx of blood into the vessel and leads to the next procedure. Second, high-frequency forceps are used to cause thermal denaturation and coagulation of the blood vessel. Although it is easy to use, it may cause delayed perforation. Third, by energizing with argon plasma gas flowing, only a broad and shallow layer on the mucosal surface can be used to stop bleeding. It is not effective for deep bleeding or large vessels, but is a good indication for vasodilatation. Fourth, a clip is used to pinch the blood vessel and mechanically stop the bleeding. There is no delayed perforation and bleeding from the same site rarely occurs unless the clip is removed. Next, we will discuss resection methods for early-stage cancer. In this session, we will explain 2 methods: endoscopic mucosal resection and endoscopic submucosal dissection. First, this section discusses EMR. The procedure involves local injection of saline or a distending agent into the submucosal layer directly under the lesion using a local injection needle. Next, the lesion is strangulated with a snare, including the surrounding normal tissue. The snare is then tightened while high-frequency current is applied to remove the lesion from the mucosa. This technique is mainly applied to colon polyps. Next, this section discusses ESD. ESD targets those that are difficult to resect en bloc with EMR. Please refer to the guidelines for each organ, as absolute and extended indications differ for each organ. The procedure begins by injecting saline and a distending agent into the submucosa directly under the lesion using a local injection needle, as in EMR. A full circumferential incision is made through the surrounding mucosa. Starting from the exposed submucosa, the submucosa is peeled off. The lesion is resected in one piece without dividing the lesion.